And welcome to this special episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the dental guy. And the isolation continues, Wes.
It continues, and we continue to podcast, John.
That's right. I mean,
we continue to do Zoom meetings and all that, even though they might be insecure or maybe hacked,
That's
Zoom
right.
bombing. I mean, like all these things emerge because of what we're not doing right now, which is we're not practicing. Right now, currently, just the state of my practice is, John, I'm shut down until May 4th. And how about you?
Yeah, that's where I'm at right now, pending more from the state, which is probably coming. I wouldn't be surprised if it's further out, but right now it's May the 4th be with you.
That's right.
But we will see if that changes because it probably will.
Well, I want to really thank all those that are watching these. Over the past few weeks, we've been streaming live and bringing you up to date to some of the most current things as far as business goes. But we want to continue in our main objective, which is to bring you great clinical content. And boy, do we have a treat for you. But before we get into what our special guests, right, are and who they are, John, I want you to talk a little bit about, I'm doing some downtime stuff, and stay tuned maybe for a future episode for me to kind of show off what I've been doing. But you guys know I'm into beekeeping, and it has been a big weekend for beekeeping in my backyard.
Here we go with the beekeeping. I love it.
Yeah, man. You remember those days, right? With the sting right between the eyes, and we were podcasting that night. I mean,
I do remember that.
Sakes, right? But
I'll never forget
John,
when you said you had to cancel your day at the office to go home and get a queen bee. That's classic podcasting right there.
I called
so
my office manager, man, and said, "Hey, they're coming in the mail, the queens.
Yeah,
and just clear the schedule.
Shut the practice down. I got to get my bees.
Practice down, man. I forgot about that until you brought that up. But I mean, bees are important, right? We got to have bees, right? Even in COVID world, right? The coronavirus world requires bees to survive. So they are an essential business, John. They are an essential business.
Yeah.
So, John, what is feeding my bees right now? You'll be happy to know that there's a lot of nectar right now coming into the hives, and you were in a place, and I want a cut scene to a beautiful picture you sent me. And I want you to talk a little bit about what you did, right?
Yeah, well, I had to get out. I just had to get out. And I mean, we've been doing a lot of this kind of stuff. This is what I love to do. We're about 20 minutes from the Appalachian Trail where I live. And I love to get up there. It's one of my favorite places to go. And I've been dragging the kids and my wife out as much as I can. They don't love it as much as I do. But the last couple of days, I decided to get the heck out of the house. And we went up to this place here. This is the top of the ridge in the Tennessee-North Carolina line. And what looks kind of like snow there is actually all wildflowers blooming. So the whole place just smelled like sweet. Walking up on the ridge line for a few miles and stayed out there and just got away for a couple days. This is the kind of thing sometimes you just got to do, and saw nobody. So it was definitely nicely social distanced and just a beautiful place to be. The trees haven't leafed out yet, but just starting to kind of wake up out there in the forest. So yeah, I needed to get away, and it was definitely therapeutic because how the stay at home order in terms of essential things is just kind of gets to a point. I mean, hiking, fortunately, is still considered something we can do. So you just got to get out sometimes, man.
Man, I'm an outdoorsman, John, and my father-in-law, it's turkey season in West Virginia, which is where I'm from. And he's telling me right now that it's just unbelievable the amount of action going on in the woods. And one thing's great, even if you don't kill a turkey, right, for sport, and we do travel. Normally I do travel during the spring to do that. One of the favorite things that I've done in my life is to go out into the woods like you're describing here, spend some time, look alone, right? And there's a lot of people that are alone right now, and they've never really experienced like this idea of solitude. And I think it's affecting a lot of people, John, in some ways a good way, in some ways it could be a bad way. And I think what I want to say this is that if you are in a situation, John, where you need to reach out to someone, right?
Mm-hmm.
I think it's important at this time that you know that you can reach out to someone, right, John?
Yeah,
Speak to that a little
absolutely.
bit.
And I think community is important right now. And that's one of the reasons why podcasting over the last few years and things like this and online education have grown and been a positive influence. And that's one of the reasons we're doing a lot of that right now, is because we think it's important to maintain that community through this time, give people the ability to still feel connected. Even though we can't have that physical touch or that physical presence, we can still feel connected. And one of the things that's awesome about what we get to do is that we get to talk to people that are at the highest level. And so we've got a real special treat for you guys today, because we're always trying to find what's next. And we've got two people with us today, Dr. Gregg Kinzer and Dr. Jill Kinzer, who are joining us to talk today about composite dentistry and kind of what they're doing in their practices. So welcome. We're glad to have you guys.
Hey guys.
Thank you.
Glad to be here. Thanks for having us.
So Jill, is this your first time on a dental podcast?
It is.
Well, welcome, right? Welcome to the show.
How does it feel?
Does
it feel good?
Well, let me answer after we're done. How about that?
Out at the end.
No pressure, right?
Let it be known though that she vetted you guys, so she's not coming in cold, right?
Right.
Oh,
well, as
She
you
did
did too,
homework.
Greg. At one time, we were afraid of Greg.
You vetted me. I vetted you guys. That's
Right.
how the game is. You don't want to go in
yeah,
cold.
back in the day, we were
know.
like, when Greg first came on the show, we were like, I don't know about he may he's a little intimidating, this Greg guy. And so we went and, but now we know we're good. But Jill, we kind of know how it is. You got to do a little background, search, make sure everything's kind of what these guys are all about.
Yeah.
That's right.
I've heard you.
Who am I going to be talking
before, but it was nice to learn a little bit more about the podcast and the history and how long you've been doing it and all of that too. So,
well, we're glad to be here.
I'll never forget when Darren, Darren Deester, as you guys will know, Darren, he, the first time when we were kind of starting to talk to some of the folks out at Spear Education, and Ben out at Spear was kind of introducing us to a few of the faculty, and we asked Darren, we were in a class with him, and we asked Darren to be on, and kind of back channel. He told one of the guys out there, I will never be on another podcast because they talk about stupid stuff. And he hadn't been on our podcast, but he had been on another podcast. And the first question they asked him apparently was, what is your favorite flavor of soda? And Darren just does not have time for that. so he was like, I'll never do it again. And when he got on and we had a great time. And I think he realized okay, these guys aren't totally joking around about everything. We can have fun, but you got to get, we want to actually put some good content out there. So we're glad to have you guys. How's Seattle doing? Tell us a little bit about what's it like out there? Of course, a lot of us know that was where a lot of this sort of began in the US, or where the first cases were being reported. And how are you guys doing out there?
Yeah, Seattle was the first, we had the first number of, deaths here because it got into a nursing home and then it kind of spread like wildfire. But we're pretty much like everybody else in the country. We're, offices are closed here. You guys were throwing dates out. We're closed here as ordered until May 18th. But we were told that could change as well. And it's a stay at home, only essential workers. So we've just been kind of working from home and trying to get content out through Spear to all of our Spear clients, and just did our first virtual seminar. So the occlusion seminar, we did it virtually, which was kind of fun last week. So it's almost like we're busier now
than he was before, at least.
But I think the challenge that we have is that we're busier with no boundaries, right? You're home and people know you're home, so conference calls, phone calls, meetings, it's like it doesn't stop.
So
and everybody
we call them gatekeepers, right, in our offices, and people that you have to go through to get to, right? And it seems like the gatekeepers have been
removed.
They're removed, and it's like
the gates are open.
And,
floodgates. Yeah.
the
So we're
floodgates are open.
we're trying to figure out our boundaries.
Yeah, and I think that's exactly where we are too. It's I mean, there's a ton of stuff you can do. The question is what is effective, and how much time do you have to put in order to put together something that's going to be quality, not just quantity. And
Right.
quantity is good, but I think that's what we're kind of all really being kind of bombarded or overwhelmed a little bit with all the stuff, especially on the business end. And that's one of the reasons we're wanting to kind of refocus more on the clinical side, because I think there's a ton of opportunity here in these types of discussions to learn something new and hopefully bring it back to our practices. And we're going to be talking a little bit today about composite dentistry, because it's an area that Wes and I are very interested in. It's been a place that we feel like for years was kind of one of the big holes in our game, to be honest, was not being able to push that as far as we needed to be able to push it. And so we've been trying to follow around people that are smarter than we are and know a lot more. And both of you guys have been heavily involved in teaching, not only doing a lot of composite restorations, obviously, but teaching the art and the science of those things. And kind of talk a little bit about that, Gregg, as far as what you guys are doing at Spear with composite education. And then Jill, also talk a little bit about your side of things, because I know you did a table clinic at American Academy of Restorative Dentistry this year about composite. So kind of talk a little bit about what you...
Yeah. So, as a prosthodontist, we were never trained in composite. That was just never a thing. We were taught to prep teeth, and we were taught to do ceramic. And then as I got into my practice, I saw that it was pretty aggressive, some of the things we were doing, right? There was kind of a shift in people wanted to do a more minimally invasive approach, and biomimetics came out. And so after attending some meetings and hearing some feedback from some of my colleagues who were from Europe, and they said, oh, your presentation, Gregg, was very nice, but you Americans are too aggressive. And I looked at what I've shown, and I could have done it in a much more conservative fashion, which forced me to go out and actually find somebody to help me raise my game. And so I did. I went and I took a class from Didier Dietschy, who is wonderful with composite. And, it was a 4-day class, and I think I got 3 main pearls out of it. But that's what I went there for, is just a couple of tips and tricks. And now it's a mainstay in my practice. And I know Jill's in the same boat, but she's been probably doing more composites longer because that's, as a general practice, that's a big part of what you would do.
Yeah. So my background, I've been practicing 21 years now, and from the very beginning, right out of dental school, just immersing myself in education, this has been a huge priority for me, just to feel competent and confident working on the patients. And initially, right out of school, I just made a commitment to focusing on techniques and perfecting as much as I could in that regard. I was fortunate enough to work with Dave Clark. Many of you know him as the founder of BioClear. And I worked with him for a couple years, and he really gave me the opportunity to use the microscope. And that's really what kind of was my ramp or my starting point from there as far as using a microscope in dental practice. I never looked back, actually. I've been using it ever since, and I pretty much use it for everything now. So back to composites and the composites that we're doing, I feel that magnification has played a huge role in really trying to perfect those skills and those techniques. But where we go with this conversation in terms of composite dentistry and how it's used, I think we really need it as one of our tools for our patients. And really today materials are there's so much available to us, and if you consider the skill level of the clinician and the materials and what's available, it's really a combination of those that's going to determine, because you could use composite for everything, really. I mean, you could injection over mold an entire tooth or cover an entire tooth with composite, and there's your crown. It's a composite crown, right? Or you could use a very, very thin conservative feldspathic veneer, and that with practically prepless type of situation. And so I think it very much depends on the goals of the patient, and what my skill set is as a clinician and what I can actually provide for the patient. So.
I think that this kind of leads me to this thought is there's a couple things that I like what you said there, is that the role of composite is even bigger now than it was maybe even 5-10 years ago, right?
Mm-hmm.
Because of we know how to handle it, and the mechanics behind, or the properties behind it, have gotten to point to where we can actually say, okay, this composite does this for me in this role, and this composite does this for me in this role. And I think whenever John and I discovered that was really our pathway through spear education led us to actually thinking more conservatively, right? It's understanding what's possible with certain materials, and then understanding the indications. And it really stopped me from cutting down teeth, especially on these worn dentition cases where you might not have complete destruction of the enamel, and you're able to use enamel and use some of these newer, or maybe not even newer composites that we understand, again, a little bit more about their properties and what's best suited for certain areas. And Greg, you had brought up some very good points about some of the things that you were changing in your practice. And I remember Bob Winter saying in one of our previous podcasts that he lamented over how many teeth had been cut down in the 90s, when he knows.
I think he said put in the pencil sharpener. I think those are the words that he used.
Yeah,
something along those lines.
I mean, that's it. Exactly. So I want us to talk a little bit about, right, this idea of what's possible now. And I think, Jill, you showed it really good in that table presentation of what's even possible in reconstruction. I remember seeing that on Instagram, and I was like, this is where I'm at right now. This is what is possible. It's amazing.
Yeah, I mean,
so talk about that.
Well, I like you to hear you say that that you garnered some of these concepts. Patient fears have been known as like that's where you go if you want to do rehabs, right? It's really aggressive, and you're doing all these things, and you're prepping all these teeth, and that for many years. In fact, there's still probably people that believe that. And as our thoughts about dentistry and what we should be doing for the benefit of the patient changed, I tried to bring that into Spear. And so we started a composite workshop, and in worn dentition seminars, we talk about the benefits, like the material section. There's a huge material section on the use of direct resin for some of these patients. So I like to hear you say that, yeah, you can see that reflected in Spear, that we're doing a more conservative approach, but still being able to treat, as you said, Wes, some of these worn dentition patients.
Yeah, that's interesting. I want to maybe stay on that thought for just a second, because Spear is very much different, I think, the Spear education experience than what I thought. And that was from day one. I really did think I was going there to learn how to prep teeth and how to do rehabs. I wanted to learn that. And I thought that was what I was going to learn, because that was maybe a misconception. And you do learn how to do that. Don't get me wrong. You learn how to do that. That's what that is.
Prep and do these big cases.
Absolutely. But you get this whole other side, which is actually in some ways much more applicable to everyday dentistry, which is understanding how to do this in a way that's the most conservative. And that can apply to single tooth just as much as it does that full rehab. In fact, I think in some ways applies more to your everyday patient, where you're thinking about transitioning patients through stages in their ability to afford care, or just how much remaining tooth structure that they have, and trying to preserve that. And that's been something that's been kind of surprising along our path with that. And it's allowed for me, and I think really it goes back to maybe one of our limitations in dental education as to why that's not the first place we start. Because to be fair, learning how to do good composite is not quick. It's not something that you can just pick up and immediately know how to do. And I think it's maybe easier to teach somebody how to, put the tooth in the pencil sharpener, and prep that tooth, because we can accomplish that in a 3-hour appointment in dental school and have that work. And I think that our education system's a little backward in that way. And we're having to kind of unlearn that now. And talk about that maybe in your own practices. Like, when did that transition start happening? Jill, you said you were using microscopes from kind of the beginning. Did that mean that you were using composite as well in these ways from the beginning, or has that been an evolution? And Greg, talk about that. Like, when did that really start to change, and what were some of the things? Was it really the classes you took, or was it materials that were changing? Talk about that.
Well, I think, right out of school, of course, you're trying to figure out like what are indications for each of these different types of treatment selections or choices, and trying to get comfortable with the materials so much. Like what is the aesthetic result I'm going to get from this or that? And of course, coming out of school, we don't have layering techniques and some of these really cool ways that we're using maybe more established dentists to close diastemas or black triangles, or, I think all of that, you end up taking a fast track really through your 2 years of clinical dentistry in dental school. And then it's your real education is actually starts once you get out and you start working with it on a daily basis and in your hands, and seeing, okay, well, that using that one color for the entire tooth didn't really give me the result I need. Now, how do I fix that, or let the patient know up front, like, okay, this is my clinical ability. This is what I can actually do for you with this material. I mean, so much of it, I think you have to work with material over time. I don't think you can nail it right away. Layering for me is still, even though I've taken so many classes on it and I work with it all the time on patients, I tell the patients up front, I want to get you back for a follow-up within a week. I need to see how this looks. I can't guarantee that I'm going to be able to nail it right away. And I think you still have to create the correct expectation for the patient that, like, we may have to modify. And if you create that expectation from the beginning, then, or also understanding what the patient's aesthetic goals are, like, can I hit them with that material, and knowing, after 20 years of dentistry, yes, I can do that predictably, or, my technician is going to do a better job at it. I don't know if that is.
That's the choice for a lot of dentists, unfortunately, there's twofold. One is your reimbursement typically is more if you're going to do it as an indirect restoration. But then you look at these anterior teeth and you go, all right, I could do it, but my technician could probably do it better. So I'm not even going to offer resin. I'm going to just go with veneers because the outcome I know is going to be better because my technician's super talented. And I think that you're missing an opportunity because, as Jill said earlier, you don't have the confidence or the competence that you're going to be able to hit the mark. And so I think that a lot of dentists don't offer it because they don't want to do it. They could do it. It's going to be the average compared to what they could do out of ceramic. And I think that mindset is beginning to change now. And I think right now in the post-COVID world, when we actually get back into practices, we have to realize that composite is going to be probably the mainstay, because as you and I haven't been working and have no income, so has everyone else. And so when we get back into practice, if you're an insurance-based practice, you'll be able to just kind of pick right back up because the clients that you're treating don't have to worry about the financial piece because their insurance is going to pick that up. But for your other patients, especially these big wear cases, they're going to go, I know I need it, but I just can't afford it right now because I haven't been working. And so if we change our mindset and think about maybe we do it out of resin and we do more out of resin, it's going to allow more patients to say yes to accepting the treatment that they need instead of just saying, well, then I'm not going to do anything. So I think it's going to be big for us when we get back into practice. It might even be bigger than where we left in our individual practices about our use of resin.
Yeah, I'll echo what Jill said too, is, John and I started our podcast 5 years ago. And I remember about 4 or 5 shows into it, we started talking about composites, kind of what we did just on a general dentist basis with what we were using with class 2s and bulk fills. And as we made the transition into different, types of materials and understanding more, I said, John, I just feel like that right now, 10 years into practice, that I feel like I'm just now feeling like I'm figuring out composite dentistry. It took 10 years to really understand it. And I think there's a lot of dentists out there that are like embarrassed maybe to even think that hey, I need to go take a composite course, but if I took that, it doesn't look good on me. No, right? Like the best courses I can recommend for you to take, and John and I've echoed this all the time, is that go take a course on just basic composite dentistry, because you're going to pick up pearls. One of the greatest clinicians that we've learned from, you guys have at Spear now, which is Jason Smithson, and we're super excited about that. In fact, nothing against you, Gregg, but
easy way.
I mean,
oh no,
no, honestly though.
No,
right, exactly.
We're very fortunate to have brought Jason Smithson on. He will start teaching composite workshops with us next year, because we were already sold out in the composite workshops that Bob and I were doing for this year. But he's such a great clinician. He's a very practical clinician, but his dentistry is exquisite. And he thinks about all of the nuances of composite, and I'm so excited that he's a part of our faculty now.
Man, it is
and I
awesome.
think that we want to focus on this. I think that, Jill, just what you said, that the time that it takes to get good at this is not a quick thing, and that's okay. And we talk to, there's people all the time, and I know you guys get these same types of questions. They'll ask us, hey, what material are you using? What material? We're so focused on that in dentistry because we like these nuts and bolts, and we think if we just switch materials, maybe all of a sudden we'll be able to achieve better results. And we do want to talk about materials in a few minutes, so we won't ignore that. But most of this, I feel like, is understanding that this just takes time. And this is where we get into that, maybe that 10,000 hours makes the expert kind of idea, that there is just a certain amount of time you have to put in. And I've taken, so many courses on composite now, Wilhite and Mopper and Smithson and, all these like masters, and you still come back, like you say, and you still have to tell the patient, I'm not as happy with this as I'd like. Let me get another crack at this next week or whatever. And that's okay. And that as we get better, there does come a point where you feel like you can be predictable, but you kind of almost have to stick with a material and a workflow for a certain amount of time, I feel like, before you really know how that's going to handle. And that's what our technicians bring to the table already with ceramics. Like, they have that. And so we know they have it, and we maybe don't have it. So, where do you think, what are some of the places that somebody should start if they are wanting to start getting into this world of anterior composite? What are some of the things they need to be looking at first? What types of courses, what types of techniques are maybe the first places that you would, talk to somebody about beginning?
Wow. I mean, obviously I've just plugged Spear right off the bat. But there honestly, there are a lot of different courses on resin. Every state dental association at their state meetings, they have breakout sessions where there's composite, but they're half-day courses. So, we have ours, and I mean, Dave Clark has. So there are so many different areas and avenues to learn composite. But I think you're right in that you have to physically do it, and then you actually practice and you play with it, and you slowly get better and better and better. It's no different than a technician starting a new ceramic material. You have to learn the properties, handling properties, the optical properties, the finishing and polishing properties. So there's like, every time you do one, you learn a little bit more.
Probably more from our failures than the case, you know what I mean? Or the cases that are the hardest are often the ones we learn the most from as well.
Definitely. And what now just getting into a little bit, since we're kind of on this line already, let's talk about, where do you start with materials, right? Because there's so many things out there, and yes, the art is the majority, I think, of this, is the artistry and the time and learning the workflow. But how materials have obviously changed dramatically as well over the last 10, 15 years. And we've got different composite resin classifications that are out there. We've got some newer generations of materials, newer filler types of materials. Tell us a little bit about what you're using in your practices now, and what types of maybe properties or things should clinicians be looking for if they're looking to get kind of to that maybe next level in their composite game?
Let's break it down like this too, because we have a lot of students that listen to this. A lot of dental students that are in D3, D4, even D1s and D2s. And what I'd like to do is maybe just break it down into the properties you would look for some bread and butter dentistry, right? Just like your simple general dentistry, class 1s, class 2s, class 5s. And then maybe get into some of the fancy things like Jill was talking about, which is some of the things that we're trying to incorporate into our practice to help people get into treatment, which would be composite, crowns, right? And injecting, like, and warming your composite and letting it flow into nooks and crannies.
And
veneers and things like that. So let's kind of break it down.
Yeah, let's geek out on some materials, though. I really want to hear your thoughts.
Because people want to hear a little bit about what to look for.
Yeah.
I think there are so many good composite materials out there on the market today. And I think if you think how clinicians evaluate and judge and pick materials, it's based on its handling properties. I think some people want something that is that's a little bit thicker. Some want it more creamy. Some want it softer. So I think the handling properties, it's too sticky, it's too soft. The polishability of it is another one that I would judge it on, handling and polish. So I think that plays into all the different materials that are out there. You pick a material or maybe a couple of materials to fill your needs, anterior versus posterior. Aesthetics versus, most of the materials now have strength. They can be used anteriorly and posteriorly. So you could actually pick one material in your practice and use it everywhere in the mouth. And that's fine. Sometimes people want, here's my anterior composite because I like the way it polishes, and then I don't like the way it handles in the posterior, so I use something different in the posterior. So I think most materials are if you were to say, okay, I'm going to give you guys this material, and I'm going to give you 2 weeks to play with it, you come out of that 2 weeks, and you'll have done everything you can think of with it, and you'll be able to start at a very high level. And then once you get to the mouth, you'll be able to get it even better. But I think it just takes time for us on these materials. So, we do materials because I like the handling and properties of one in the anterior, and I like some different properties in the posterior. Again, it goes back to handling. So,
yeah. So you're not really looking at it as much from a strength standpoint as you're thinking about, because that was for years, right? It was, you had your kind of a trade-off for years was, you had microfill and you had your microhybrids, right? And so you kind of had to choose between those two. Do you feel like that, first off, is there a place for microfill today? Or are we into these newer materials where we really don't need that anymore?
You're right. For years, like Cosmedet had its you had your strength material, your hybrid, your microhybrid strength, and then you had some nano materials, and then you had your pretty microfills that you would put on top. My personal thought would be, I don't think there's a place for microfills now. And the reason is, I think that the nano materials that are out there, if you think about having one that has great aesthetics and polishability, and one that has great strength but low aesthetics and polishability, the nanos have actually taken the good of both of those without the bad, and all of a sudden you have a material that is polishable, maintains its polish, and has strengths to be able to manage occlusion and edges of teeth. So in my practice, in our practice, we don't use microfill because of our needs are getting met really well with the nano materials.
I can see, though, in a case where maybe there isn't a wear issue, or it's a trauma case, the person's, they broke it by the chipping something, so it's a low risk case, that material is beautiful and you can get such a beautiful aesthetic result from it that, I think it does have a purpose. But the super nanos that we get with Estelite, again, it's like we're getting both. So,
yeah, if I can get the same polish as a microfill, but also have strength if you wanted to function on it, then why would I want something that doesn't have the ability for you to function on it without increasing the risk of something breaking? So
exactly.
You had mentioned one time at one of the courses we took that, and it was some of the things that I was running in with some of the products that I was using, is this polishability of this finish line, right? And in the posterior, that's why we have we're moving to 2 composites as well. I know, John, you've already moved to 2 composites for this very reason, is that some of the microhybrids, right, which traditionally have had a really nice chameleon effect and fill a role and a need for most offices for just the single composite that you could use throughout the mouth. But then as you gain experience with a microhybrid and you start to apply it to like pathway wear, and you're looking at an infinite edge of polishability to where that polish line just disappears. Like you just can't even see the margin or even tactilely feel it. Even at the end of that, those patients came back to me and I was like, I'm starting to see a little margin here. And I know because I've got photos of post-operatively how you couldn't see that, but it was almost impossible to get that because of the characteristics of that material.
And that's where the materials really start to matter, right? You start to get into where some of these newer, and speak to that because you mentioned, that brand. That's what I've been using in my practice for years now. This whole idea of, I think and correct me if I'm wrong on this, I think they're like the only company that has this spherical filler material, and I think that's why we believe that the margin is polishable. Is that kind of your understanding of why that material works as well as it does?
Yeah, I mean, so it's a super nano. It has a high filler content. It's got spherical filler particles, and I think that's what lends itself to having the infinity type margin. Don't have to finish it back to a set margin. And some of the nano hybrids, if you think about the nano hybrids, it's still small particles, but there's some big chunks, and then there's some conglomerates, right? So there's nano clusters and there's nano particles, which makes up their hybrid. And I think because of that, and you start finishing back and you get these fillers that pluck out, you are going to have the ability to see that albeit faint, but it's still there. You can see it. Yeah. Depending on your magnification, you might be able to see it more. So
can I just mention one thing on this while we're on this topic of this product?
I know where you're going.
Why? I'm sorry, but why are they the worst marketers in the world? I don't understand it. They have this great product.
Are you going to call them out on the show?
We already have. We've done it.
We have called them out. They know us.
We need to do their marketing or something. I mean, God, because they have all these great ideas. I mean, look, this is probably one of the companies that currently has some of the best idea products on the market in various areas. And but yet they, you go to the show and they have this tiny little booth back there. And I don't know what is up with that. Do they just not? It seems like a lot of Japanese companies in general are just not really great at marketing their products in the U.S.
Population?
No, like marketing. They don't. Do they not care about it?
Yeah, I don't. Yeah, it's.
It is such a great product, though.
Yeah, it is. And they're very forward thinking. They're omnichroma. I mean, it's like that's thinking optically differently than other companies. So it's impressive, but you don't hear much about it unless you're in their environment. You wouldn't know.
And Curare is the same way, and GC is the same way. They're just, you don't hear about them as much. It's just interesting, and they're producing such a great product. So hopefully, the more we're talking about this, the more people discover maybe some of these new things.
I hope people find out about it because we just think it's an amazing product. It's one of the reasons why. I mean, I've been a 1 composite guy for like forever, and I'm starting to switch to a 2 composite guy, and I would never have said that. And with Estelite, I think it's amazing. You brought up something, Greg. I think it's time to get into it. It's magnification. And we did an episode called I'm Addicted to Magnification. Now, we didn't take it to the level that Jill Kinzer takes it to. But we have talked to people like Alan Mead, who has like microscopes in his hygiene.
He's truly addicted.
He's truly addicted to magnification. John uses 4.5s, and John, I think you've ordered 6.0s, and I use 6.0 magnification in mine. I'm not afraid to mention the brand because we just love our stuff. But if you want to go back and listen to I'm Addicted to Magnification, we talk a little bit about why high magnification loops will change your practice. But I want you guys to speak to a little bit about, you said there, like if you have good magnification, you can begin to see some of these particles kind of flake out. And as I moved to 6.0s from 3.5s, I was like, oh my gosh, I think I've finished margins on tartar in my crown preps. Because you know what I'm saying? Like interproximal between like number 2 when you're doing the crown prep, and you're like, hey, there's some tartar, and you scrape that off and like, oh, there's enamel. Like, I'm wondering how many margins I've finished on tartar before when you go to these higher magnifications. So speak to magnification, what it does for composite dentistry.
Oh gosh, well, I think magnification in general just is a game changer for dentistry, as you said too. So whether it's loops and going to really high magnification with that, the challenge with that is usually the light source. So pairing it with a really good light source is super important. I think the higher you get with loops, the challenge is that there's some motion just from your head and
So there is a progression. So I moved to 8 power with 2 light sources. That's my regular loop. But the challenge is your head, like I can feel my heartbeat with my loops. Like they'll move a little bit. So if you have any type of a head tremor at all, then it's unusable when you get to that power. So that's as big as you can go, I think, with a loop, 8 power. But then you need, I stole Jill's headlamp. I have a light on the loops. Yeah. So that's great because it's like the eye opener again. Wes, you say I went from 3.5 and I went up to 6s, and it's like, holy crap.
Yeah, but with a microscope, you can sit upright. You're in
the microscope. Then is the next step. So,
my happy place is between, I'd say, an 8 and a 14. That's where I live really in dentistry, and I use it for everything. So every once in a while, I will bump it up to even like a 20 plus. It's if I need to see like what is that on the margin, that enamel or tartar, or maybe even diagnosis, like for an emergency patient, is that a root fracture? So
you get addicted though. You can't go the other way. You want more. Like once you see what you haven't seen, then you want more. I want more magnification. I want more light. And with resin,
that's what we've had the same problem. And the 8.0s, man. I mean, that's big. That's big time. I mean, talk about that a little bit, because we had another guy that we know that talked about the 8.0s, and he felt like it was almost too much weight, too much of that, like you say, that tremor issue. Do you feel like that? Because we're looking at that. And do you feel like it doesn't make sense versus just going to a microscope, Greg? I mean, do you feel like if somebody's looking at those, should they just make the jump, or should they does 8.0 make the most sense?
8.0 is a tough one, I'm going to say, to pull off for most clinicians. It's heavier, and there is a little bit of you can see some more movement with it. So I would say I would not just jump into that. If you're really interested in more magnification, then I would strongly look into a scope as well. The challenge with magnification is jumping up in your magnification with the loop stays in tune with your game. You're used to using loops. When you jump into a scope, it's like starting a new material. You have to relearn what you've done before. So there's a learning curve that will slow you down. Not for Jill, because she's been using it for so long. She's like really efficient with it.
It makes me faster, actually. I feel better.
Yeah. But I would say 8s. If you're thinking about going to 8s, I would say I would also maybe think about other magnification, maybe a scope, or maybe the new 3D that's coming out, which you don't have to have a microscope for with certain companies. Other companies, if you already have a scope, you could run it through your scope. But I don't know, with this post-COVID world, if you think about aerosols that we have, the scope users are going to be, they're farther away from the patient. We can break things. We can keep it's like, there's going to be some big changes coming out of dentistry as a result of this.
Yeah.
So I want to go back to you asked me specifically about magnification and how it changes it, like my composite game maybe. I think one big thing you mentioned this, Wes, is just evaluation of the substrate and being able to really look at what I'm bonding to. Do I have clean enamel? Are there cross-cut enamel rods? Is it undermined or crushed, or is it going to flake away? Is that going to be the weak point in the longevity of the composite? The other would be polishing. being able to really see where that finished margin is, and am I lifting it off the tooth, or am I actually helping it move down and improving the bond with that as well. So I don't know, I'd say those are two really big things that have, and also, like I'd say with removal of biofilm, we do air braid the teeth before we bond and do any bonding at all, and just making sure there isn't any of that biofilm or debris on the tooth that's going to interfere with. I just feel like I can see so much more that is going to
absolutely
make it less chance of failure and more predictability.
With composite that blends into the tooth and it polishes similar to the tooth, man, if like under a scope, even with my 8 loops, under a scope, you can see so much more. I mean, it makes you that much, I think, makes you a better clinician because you're able to see more than you would without having that high level. Because everything just blends in. It's just, oh, great. And then you look at the scope and go, no, it doesn't look as good as I thought it did.
John, is this convincing to you?
Well, I mean, it's challenging, and I like that. I mean, I think that that's what we need to be thinking about, is how far how good can you really be without this? And I think that's what we should all be asking ourselves. And I have to mention just briefly, Jill, I appreciate the fact you called it the substrate. I just love, we're among fellow nerds and geeks when we call it the substrate. It's beautiful. It's beautiful. But I think that the question of how much is enough, right? And maybe the best way to ask that is, you guys have been around a lot of very high level composite dentists. Do you feel that there's anybody that's doing it at a super high level without a scope?
Oh, I'm sure there is. I'm sure.
I mean,
who's
teaching it though?
Bob,
but who's teaching it? I mean, everybody that's teaching it is pretty much
John,
doing
you're
it
not
that
doing
way,
it at
right?
a high level because you're not using a scope. Greg's will tell you.
I know, that's what I'm saying. I'm feeling maybe inadequate just a little bit, and that's okay. Like I mean, I want to know if I need to do it.
Every instructor is using it because it's the way to teach, so you can see what it is that I'm doing.
Yeah.
And I think that when you do that enough, then it'd be silly. Like, why would I get back into practice and then not use a scope?
Not do it.
Because you it from a different side.
Talk about because this is, of course, where people start going when they start hearing about this. They start thinking about the in general idea of time and cost effectiveness of composite, because I think that's one of the big barriers, not only to microscopes, but also to composite in general. And Jill, you made an interesting comment just a second ago. You said it makes me faster. And, talk a little bit about that as far as comparing ceramic, assuming you can do a minimal preparation, right? So let's assume it's not a decision between buzzing down the tooth or doing composite, right? Let's assume we can do minimal preparation and you're just trying to decide between composite and ceramic. And let's talk about the time factor of that and how that works in your practices. How do you deal with the cost and time of those two restorations when you're discussing that with a patient? Is it similar? Or is there a huge variation in that? Is it truly a low-cost option, especially in the anterior, or is it actually similar? Because sometimes the time can be, pretty involved.
So this, I'm going to throw this one to Jill, because her table clinic she did for the Restorative Academy was basically talking about comparison of materials, and it was in the aesthetic zone. So it was the incisal edge, and it was comparing ceramic to composite. As a clinician, that you're going to have to make a choice. And so she laid it out, and she had some guidelines that kind of we had thought about and we follow in our practice. And so I'm going to let you kind of talk about how you would choose between those two.
So John, do you want me to go back and touch on the microscope first at all in terms of like learning curve and any of that? Or I don't know if
Yeah, I mean, I think that's a good starting point is, learning curve and getting faster, so that it can become cost effective or time effective, but then also maybe just dovetail that into this idea of choosing between the materials from a cost and a time and a strength standpoint. I mean, that's really, those are the two really, I think, big questions people ask about, should I make the jump essentially into these things?
Sure, yeah. I mean, so I'd say steep learning curve right off the bat using a microscope. It's not like you just pull that thing over and immediately hit the ground running and can use it. So getting comfortable on it in a non-clinical setting is the best. Like anything you can do indirect. So trimming your temporaries or evaluating a crown before you go to seat it. Anything that's direct vision that you can do without having to worry about mirrors and manipulating, any pieces or using a handpiece at the same time. I mean, that would be my encouragement to, and with any new magnification you're using, I think you kind of have to take baby steps, and then you hit that steep learning where you just like take off and with it. So for me, initially, super hard. Yeah, I mean, everything took more time. It was more challenging, and it was a little bit of a battle with my team. Even every time I pull the microscope over, they're like, "Oh, great, this is going to take twice as long." So that definitely was a challenge. I got to the point where I just had to tell them, like, look, this is happening. I'm going to be using this for every procedure, so I want you to make it available, and it needs to be like as easy to pick up as a handpiece. And once they accepted that and they were on board with it, then it became, I had the support I needed. And yeah, so procedures took longer at first, but then I got to the point where all of a sudden things became easier because of it. I didn't have to, and the way I think about it now is, so I'm in my 40s and presbyopia is sinking in, and I wake up in the morning and like I cannot read, and I have to get glasses so I can actually read. So I could read, but it would be a lot harder to do without the glasses. So I think people don't know what they don't know with magnification until you go to having like putting on the glasses and actually seeing clearly what you're missing. So, could I do these procedures without? Well, of course I could, but I already know I'm going to do so much better and be so much more efficient because I'm not going to have to fuss over these different things later in that path. So I don't know if that helps at all with, I'd say it took about 18 months for me to really get, and that's just being committed to using it every day for some procedure. And then before I knew it, I was using it in the mouth, really more indirect procedures and drilling and doing, but I can't even imagine now trying to do like an MO on number 15 without it. I mean, there's no way I would want to. The other thing is with the microscope, you have to use a rubber dam. You need to get the lips and everything out away from the site where you're drilling. So I'm not fussing over all of that. It's very clean and isolated, and it's a lot, I don't know, that you have to become a rubber dam dentist if you're going to use a microscope too, I think, at least for posteriors. Otherwise, there's too many things you're dealing with.
Yeah, it totally makes sense because, when you're going in and out of the mouth, it's easier to know that you're not going to rub your handpiece into the patient's lip and bringing things from into that maximum. Mm-hmm. I mean, you're going from a massive magnification to, a non-magnified world. And, that's always really hard for some dentists to kind of manipulate. Well, all dentists really in the beginning, it's really difficult to do that. It becomes second nature though. And for people wanting to get into this, as far as, taking maybe their magnification up a notch, right? Where would you start with that? I mean, like, let's say you're at 6, you may be even at 8 O's and you're thinking, you know what? Kind of want to think, I'm thinking about getting into this.
Yeah.
How would you go to, where would you go to learn?
Well, I would encourage anybody who's even interested in a microscope to call a local rep. So Global, Seiler, Zeiss, those are 3 amazing companies. They all have a great product. I've worked with them, and just the people are wonderful. They will bring a demo to you often and let you use it for a week, 2 weeks. And so you can actually have that and see how much you can integrate. And so that's just something to put out there. I don't think people realize that they can use that as a resource or a way that they can actually test it and see, it's when you go to these meetings and the vendor shows, how are you really going to test, you know what I mean? How do you get to try it really? And you need to get it in more people's hands so they can actually try them and feel like this could be part of their practice more. But
that's
so
good.
anyhow,
that's a good challenge.
I don't want to walk to the microscope and too far with this. I know this podcast is supposed to be on composites, and you asked quite a bit about my Restorative Academy table clinic, so I want to go back to that. So it wasn't so much on composite as it was really reestablishing an incisal edge, and this is something that we all do in dentistry. It's a very common procedure, but it's also one of the most challenging because the exact reason that we're treating it, and it's wear, trauma, and people want improved aesthetics. So the table clinic really focused on breaking it down in terms of material selection, prep design, occlusal goals, those things that, but.
So your question was ceramic or composite. And I think that we would agree that they're interchangeable at this point in time. The choice depends. I mean, how good are you with composite and how good is your technician with ceramic? So that's the playing field.
Well, you got to go through questions like
aesthetically, I think it's a non-issue, and I actually think functionally, and we've had these discussions before, but function is more of a part of occlusal design and how you manage the anterior relationship than it is about material strength. So in the anterior, you'll have your own set of values as to how you would choose to do it out of resin or out of ceramic. But let's just say that you can get the same results out of either.
So I sort of have a series of questions that I go through and ask myself, and when I'm evaluating a case to determine which way this is going to go. And yes, as Gregg said, I think understanding the patient goals, if they are okay with it being a monochromatic, color and tooth, and and they're more after maybe the shape, and you can accomplish it, then maybe that's a perfect scenario. But I kind of go through this series of questions. So the first is, how much material needs to be added? Is it a small amount that we're adding, or is it a larger amount? So if it's a small amount, composites usually an easy solution, right? But if it's larger, then there's going to be some other questions I need to ask too. And then, is it one tooth or multiple teeth? So if it's a single tooth composite, maybe easy. If you're doing like a class 4 on every single tooth, okay, so how is this going to work in my hands? How is the material going to work, and what kind of aesthetic result am I going to be able to provide for the patient? I have to ask those questions. The third is, do you need to change the aesthetics of what's remaining? So if it's, one or multiple teeth, if you're making big aesthetic changes to the overall look for the patient, that's really going to come down to, how comfortable I am doing that in composite versus what I think maybe my technician can do. And so I think it really, like as Gregg said, materials can be interchangeable today. It's, so if I can do it in composite, but maybe I don't have the ability to add in translucencies or chroma or coloring, layering, or, then maybe that's not going to be the best solution for that patient if that's their goal, is to have.
Well, it's a timing. I mean, I think that the way that she just broke it down is nice. How many teeth and how much material, and are you changing the overall substrate? So now you say, okay, you're going to do some incisal edges on 6 teeth. Great. Big class 4s on 6 teeth, I'm going to be more efficient if I did them as veneers.
Yep.
Do I want to change the aesthetics of the whole tooth, or am I just adding it on the edge? 6 veneers out of composite where I'm masking dark teeth, or 6 ceramic veneers, I think I'm going to be more efficient clinically to do it out of ceramic.
Well, and the dark tooth is interesting too, because if you can't internally bleach, or you may have to cut back anyhow. So now it's like, well, if I have to cut back anyhow just to get the thickness of material to mask that, I may choose ceramic anyhow, because so. And then
how does dentin availability? How does dentin availability affect decision making? With ceramic veneers, we talk so much about that, and there's different camps on that. As far as how much enamel is enough. Does it change with composite? With the bonding we have today, do you get concerned about when you have lack of enamel with making it a decision between ceramic and composite, or is it really the same type of decision making that you would make with ceramics?
I think it's the same decision, really.
Yeah.
I mean, I really do. You need as much enamel as possible to bond to. With composite, we can always kind of push our margin a little bit thinner, farther, maybe down the lingual to get something to grab onto that's going to give us a little more secure of a bond. Whereas with, porcelain, we have limitations of the material, like how thin can it be and such. But I think, of course, I think there's always play role, and there's a trade-off sometimes, right? Like you're going to spin a tooth down to get maybe something a little more aesthetic that's going to mask, or do we go with something? Yeah, I mean, I think you just have to evaluate substrate and really look at what do you have to work with and what's going to be the most predictable. And when this fails, then what? Because there's always
Yeah, and enamels, I think, still a big part of our treatment planning for strength of the tooth, for better seal, for longevity of our bond. So yeah, that still plays in, whether it's ceramic or composite, still plays in the same way.
I think, the thing about this podcast that really makes me kind of like love to kind of sum up things a little bit is we've talked a lot about what at Spear Education, you learn how to create awareness, right? And what we're talking about there is you learn how to create awareness for what is possible with what I'm seeing right now in this patient's mouth, and I'm presenting that to the patient, and I understand what's possible for them because I've seen it done. But it's also understanding about creating awareness to your own self as a treating clinician. I'm now aware of what is possible with some of the material choices that I have. And this decision tree that you talk about, Jill and Greg, it's so important to start to map that out as a clinician. And if
and I hear you saying, something that I think really bears repeating, which is, you're not really making this decision anymore based on the material. I mean, you are to some extent, you're saying, hey, certain things we can do with masking, for instance, but in really it's about time and efficiency and who's going to just do a better job in terms of making this look great for the patient, functionally and, material wise. I don't hear much discussion going back and forth about that. Essentially what I'm hearing is it's relatively equivalent. You could have a discussion about thinness potentially in some of these situations, but it sounds like it's more coming down to your own ability and the time and your technician's ability. I mean, is that, am I hearing that right?
And also the age of the patient matters too. I'm not going to go spinning down teeth on, an 18-year-old. I don't know. I think there's a lot of things that play in, but yes.
You're absolutely right. It is, if my outcome is what's driving me, right? My outcome has to be functional. You can use it to do whatever you want. It's got to be aesthetic. You can do that with either material. If you have the confidence in your clinical skills, you can do it out of composite. And if your technician is talented, you can do it out of ceramic. So then you go, okay, well, if I can do them both, which one do I want to do? It's going to take me too long. Like I could do composite, but it's going to take me twice as long as being able to do more minimally invasive veneer preparations. So it's not a material discussion anymore. At least it's not a material discussion. It's how does it fit into what we need to do for said patient.
Yeah. So I want to ask.
I think that's a huge paradigm shift.
Huge,
I love it,
man. Well, I was going to ask him so basically, I want to ask you in particular, each one of you, as you've grown as clinicians, do you feel like you're using composite more or less now?
I would say more, but in different, maybe it's just different skill set and different confidence too. And
coming from when I started practice, like 100-fold more, because we just didn't do it. But now there will be entire weeks where all I do is resin, which is unheard of 10 years ago for me, or 15 years ago. Like it was unheard of. So it is a mainstay, and it is the kind of the first go-to material.
So you would just say that it is the most indispensable material you have right now in your practice?
Absolutely.
Yeah.
Yeah, absolutely.
That's a big statement, John.
Yeah.
And
that's something that I think is.
There's a lot you can do with composite that you cannot do with ceramic, whereas there's not as much you can do with ceramic that you can't. You know what I mean? That you can't do, and they're not the same.
Yeah, patient costs are lower for the patient as well. I mean, it's a benefit for them, and it's benefit for the teeth.
Right. It's hard to make a case if it's your mouth, right, for not doing it. In the end, I mean, if it's your mouth, and what would you want? In majority of these cases, assuming again that you have the skill, the technical skill to make it look great, and you understand the occlusion side of it, which obviously is super important here. And I think that's why you guys are setting this up in a good way. We kind of started talking about at the beginning of this discussion how we've evolved. And that evolution didn't come from just a new material. It came from just taking material that we've had around, but learning how to use it appropriately. And that starts with an understanding of where should we use it. It's really about occlusion and design. And then it just becomes, do you want to become a true expert with this material? And we have now a lot of tools like magnification. And then really it's just a matter of putting in the hours, putting in the time, and learning how to become great with it. So man, this is great. And I think, as much as this is not a new discussion, it's still new to a lot of clinicians. It's still new to a lot of clinicians because they're still graduating with the same type of training that, composite is for this and ceramic is for this. And we're really still, it's every new dentist we talk to about this, where we're telling them what should they start with. And it's just, a lot of it is just, again, go take some basic courses on composite dentistry, get good at composite, get good at bonding, understand those things. And they really are not taught a whole lot about that coming out. And it takes years to get there. So in kind of closing this out, to respect y'all's time, again, talk about where people can go and find out more about what both of you guys are doing. Kind of tell us where can our listeners go if they want to connect with you guys and your teaching or kind of your lecturing, or talk a little bit about that.
Yeah, I mean, everything I do mainly is at Spear Education. There is a piece for composite at Spear Education, but there are hands-on courses, and I think there are other hands-on courses of people that are out there as well. I
think having Jason Smithson come in too next year is going to add.
Fantastic.
Yeah, it's going to add some new pieces to it it'll be interesting. I hope a lot of our loyal, Spear Education followers that they come back and they take that again, and because I think there'll be some really good pearls and new information in that he brings to that whole course. So I think awesome. As far as what I'm doing, I'm saying yes to lecture opportunities that I get, and it's a little bit here and there. I've spoken to the Microscope Academy and at the Spear Summit, and then at the Restorative Academy meeting this year. Was supposed to speak at the AO with the dear friend Ashley Hoders, periodontist that I work with, and right now, we're all sort of in a holding pattern. But I do mentor at Spirit too, so that's really kind of where I am.
Awesome. Well, it's been great to have you guys.
Book if they want to connect.
Yeah, you're all over the socials. Yeah, your Instagram game is
next level.
Quite good. Yeah.
Yeah, so if you go over our business page, which is Spear Aesthetics, and numerous people would come up and say, "Hey, I want to hire your designer. Who's doing that for you?" And I'm like, well, she might be kind of expensive because it's Jill.
I know. I've been following it for quite some time, and I really did not know that it was you doing all of that until maybe just recently, when I started to see that it was actually you posting the stuff and not some artist, but the artistry is there. So thanks guys for being with us today. And for those who are listening, go check out Spear Education, check out what Jill and Gregg are doing. And also, of course, like and share, give us a 5-star review on Apple Podcasts if you're getting some good value out of this content. And we're going to be bringing you lots more great content over the coming weeks. And so for Wes, for Gregg and Jill, I'm John. We are the Dental Guys.
All right, we're off.
Good.
Thank you so much.
That was awesome.
That was really fun.
Thanks, guys.
Yeah.